My topic is the value of TEE and 3D echocardiography in protective valve disease. Although valve repair is frequently performed, prosthetic valve implantations by surgical or non-surgical technique remains the treatment of choice of patients with significant valve lesions. I remind you the prosthetic valves, the ideal prosthetic valve has excellent hemodynamics, long durability, high thermoresistance, and excellent stability. Two types of prosthetic valve is a mechanical and biologic prosthetic valve. I start with a biologic prosthetic valve. Biologic prosthetic valve is divided into three kinds: stented, stainless, and percutaneous. This is the new one. Percutaneous bioprosthetic valve. This is the picture of a stented biologic prosthetic valve, and this is the stainless. The last two is a percutaneous prosthetic valve. And mechanical valves is three kinds of mechanical prosthetic valves: bileaflet, single tilting disc, and the others one is a cake ball valve. Echocardiography is a demanding procedure in performing and interpreting, and I think this echocardiography, TEE and TTE is a diagnostic technique of choice for identifying the type of processes, assessing its function, and diagnosing its dysfunction. And we have to obtain the comprehensive evaluation of prosthetic valves, clinical information, imaging and Doppler echocardiography of the valve, and other echocardiographic data and available previous post-operative study. For TEE, diagnosis of prosthetic valve dysfunction is to identify the prosthetic valve type, detect and quantify transvalvular or paravalvular regurgitations, detects annular dehiscence, detect thrombosis and venous formations, and lastly, detect and quantify valve stenosis. This is the images of a mechanical valve. This is the kickball valve. You see here, there is a movement of the ball. This is bileaflet tilting dish. You can see here by TEE, very nice motion of bileaflet tilting dish. This is a single tilting dish. You see here. This is the bioprosthetic valve. This is the percutaneous aortic valve. You can see here. This is a mild regurgitation after implantation of a cutaneous aortic valve. This is stainless, and this is stented of mitral valve. The third, you also have to detect and quantify transvalvular and paravalvular regurgitations. This is a normal flow of the single tilting disc. There's a valvular regurgitations. There's a normal. This is a kick and ball. This is bileaflet tilting disc. There is a normal transvalvular regurgitation. But this is my patients with the prosthetic endocarditis. You see here paravalvular aortic regurgitations and rocking motions of the valve because of endocarditis. TE also can confirm the proper valve settings. This is the normal setting of the mitral valve. No rocking motion, but these images show rocking motions of the prosthetic aortic valve, and there is a peripheral abscess due to the endocarditis. TE also can detect the thrombosis or venous formation on the valve. This is the thrombus of the mitral valves, and this is the venous formation of the aortic valve prosthesis. And you have to measure the thrombus area, because the thrombus area less than 2.85 cm square is for lower risk for embolic phenomenon or death associated with thrombolysis. Detect also the valve stenosis. This is a normal spectral display of the aortic valve, and this is the obstructive. You can see here the increasing of the pressure gradient transprosthetic valve. How is the value of TE and 3D echo? Again, this is the image of a prosthetic dehiscence. Compare TEE and TTE. This is the images from TTE. You can see here there is a shadowing of, because of a shadowing of acoustic shadowing. So you cannot see clearly the rocking motion of the valve. Compare. This is the images from TEE. You can see the clearly the motion of the prosthetic valve. TE also can differentiating thrombus from venous. This is a study from John. He measured the length, area, and video intensity ratio, and he concluded that video intensity ratio is accurate for differentiating thrombus from venous. If the video intensity ratio by TE is less than 2.7, thrombus has a sensitivity 100% and specificity 71%. If less than 2.4, 100% specific for thrombus, and more than 2.7, 100% for specific for venous formations. Another case report from Kodali, they perform continuous TEE. This is one case of female patients with the acute prosthetic mitral valve thrombosis. From TTE, there's a poor image quality, but they found high diastolic pressure gradient across mitral valve. TE confirmed thrombosis with the area measures 1.4 cm square. Performing continuous TE is because to prevent any complications associated with re-intubating the esophagus and provided the ability to continuously monitor the efficacy of thrombolysis in these very unstable patients. And the result is thrombus began dissolve within 8 hours with RTPA infusions, and after 20 hours, the majority of thrombus has dissolved, and patient no longer require